We can have the last panel of the day. So the last panel today will be moderated by Ruth Parker. This panel will function in the same fashion as we did with our first panel. The questions will be posed, and each panelist will be asked to respond. And as I said, Ruth Parker will moderate those responses. Ruth, as you know, is Professor of Medicine and Public Health at Emory University School of Medicine. And Dr. Parker will then introduce each of the panelists individually. Ruth?
Okay, great. So where's the beer? So that would be the first question, right? So I will assume it's coming. And in the meantime, welcome to the last session. This should be a good discussion. We get to go on top of a lot of other great presenters and some great content that's been presented. So my personal thanks to everybody who's gone before us and given us a lot to think about and for us to try to put a little bit of cohesion to before we hear from you all. I'm impressed with a lot of the questions that we're getting from the audience, and I did, when people caught me in between, I said, what's your question, to see if anybody had any burning questions from the floor before we start. So we will definitely be looking for those, and I'm assuming there's some people who've got some good questions that they want to pose to the group as well. We have a few that we came up with on the front end, and we'll use those to get the conversation started. But as you come up with burning questions, know that we want to hear from you. So let's try to make this something that is fun and interactive. So let me introduce my new friends here and welcome them. Dr. Cara James is the Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. The mission of the office is to improve minority health, reduce health disparities, and to foster health equity. Next to her is Laura Morris. Laura is the Assistant Healthcare Advocate in the Office of the Healthcare Advocate for the State of Connecticut. Her office assists consumers with healthcare and healthcare coverage issues. Next to her, we have our own very dear Kim Parson. In her current role in the Corporate Consumer Experience Center of Excellence, she's part of a collaborative to define the desired Humana consumer experience. And then next to her is Mila Kofman. She is the Executive Director of the Washington, D.C. Health Benefit Exchange Authority, the mission of which is to implement a health care exchange program in D.C. So welcome to you all. Thank you for being here. That's but a very small portion of what you do. Lila, do we want to use the questions or not? You may just, yeah, we do. Okay. So we'll start with, boom, there they are. So I am going to ask each of them, if they will, to sort of take the question that's there posed in front of you. If you choose not to do lessons and opportunities, I'm going to ask you at least to take a look at that. And based on what you've heard today, based on the focus of the Health Literacy Roundtable and the whole notion of health insurance literacy and the way we've looked at it today, I'll ask you to start, Cara. What do you want to underscore as the big opportunities? There are a lot of them, but give us a couple of the ones that are burning from where you sit.
Okay, so thank you for having me here today. It's great to be here. In addition to directing the Office of Minority Health, one of the things that we've been working on is from coverage to care, really helping consumers understand their coverage and be able to connect to particularly primary care and preventive services. And I think that there have been so many lessons and opportunities. You've heard how HHS has evolved its efforts over the past couple of years and how we continue to do so from the learnings. I think one of the lessons and opportunities that relates very much to that in-person assistance that particularly some of our minority communities are looking for and find very beneficial. One of the lessons and opportunities is really just the value of partnership. And I think at HHS we've gotten better in doing that, engaging our partners earlier in the processes. So you've heard about, feedback on the notices and notifications. How do we engage? What resources and tools that we can develop? How do we support those who are reaching out and engaging with the consumers to enroll them, our assisters? What do they need to be able to do the process better? So that's one, I think, both lesson and opportunity of how we can continue to support those activities. I think, the successes we have seen, particularly the number of people who have gotten coverage is a success. We're starting to see more people using it. I think we still have a lot of opportunities and lessons there. A lot of people fearful, you've heard, about using their coverage because they don't know how much it's going to cost them. So how do we help to make those sorts of information more accessible and more understandable? I think, the navigation, the complication and fragmentation of our healthcare system makes that a challenge for us. But within the confines of what we have, I think there are a lot of opportunities for us to do that better. So I'm going to stop. I could go on.
Good. No, that's good. That's good. Laura.
Hi, thank you for having me. I'm glad to be here. Just a few things about our agency if people don't know. So we are a consumer assistance program. We're a state agency. We're a standalone agency. We have 19 people in our office. We really have a threefold approach to our mission, which is one, to educate people about the rights and responsibilities under their health insurance plan. The second is to help them when they have a problem. So whether it's they're being denied a service or a treatment, we help them get that covered, whether it's through an appeal or billing and coding issues, whatever the issue may be. And then third is legislative and regulatory action. So anytime there's any new legislation in Connecticut regarding health insurance, we're there monitoring that. And then if we do see any issues going on with the carriers in Connecticut, we may need to go to their regulatory bodies and ask them to step in and regulate. So sitting from where we are, there was a lot of overlapping themes that I've heard here today. I think the biggest one was the importance of having that in-person assister help with not only enrollment, but now education and understanding their plans, how to utilize their plans to the best of their benefit. But I think one of the areas that's lacking is how do we continue funding that? I mean, there were other underlying themes, but I think that was the biggest one for me.
Hi, okay, thank you. So yeah, to build on, because I heard the same things that you all have already mentioned, so just to build on that, what I would say is we heard that navigators are not just necessary when you're selecting the plan, right? But as you start to use that plan. Because when you're selecting your plan, a lot of times you don't know what you don't know, right? So I'll give you a couple of examples. My son was diagnosed with ADHD. Well, this was in the middle of my plan year, and because he hadn't had that previously, or we didn't know about it previously, when I selected my plan, I wasn't concerned about what ADHD medicine was in which part of the formulary, right? And so that was a surprise experience for me when I got ready to use my benefits after I'd received a diagnosis, right? That the prescription that they were looking to put my child on was going to be in the highest formulary tier, right? So there's no way to plan for that when you're selecting your benefits. You don't know what you don't know, right? So I think when we're thinking about navigators and how they can be helpful, it's throughout the process, right? You really need someone to be able to walk with you throughout this. And this is whether you've had insurance all of your life or whether you're new to it, right? As another piece of that is as we know, when you're navigating health, if you're sick, that can cause problems, cognitive problems, your abilities to be able to make decisions about these things as well. So, one of the themes I heard was the importance of help and navigation continuing throughout the process. And I think that partnerships is a key way to getting to that, because when you're talking about, we lost the funding for that, right? Well, it can't just all come from government funding.
token. Are you all awake? Great. I have to say, this is the toughest panel. We're the closers, and we know we stand between that beer, wine, seltzer. So we are the last, and hopefully it will be worth it for all of you who are still here. I very much appreciate being invited. I think I'm the token representative of state-based marketplaces here. Okay, so you have to be on best behavior with me. I'm very proud that in DC we have a state-based marketplace. It's called DC HealthLink. My team and I are responsible for it. DC was the last state to start building our online IT system. And the good news is that we were one of 4 states that opened for business on time, October 1st, 2013. And we actually stayed open all day. And we opened for group and individual, and we were also designated as a source of coverage for Congress. So we have members of Congress and their staff, including their district offices. I'm proud to serve all of my customers. But one of the lessons for us that first year was we were so laser focused on the technology and focusing on the core functions, building a system that has never existed before. Imagine instant eligibility for Medicaid or private coverage. It's quite remarkable. There was no roadmap. We focused, but the price we paid was that we didn't focus enough on customers, what they needed, the kind of tools they needed at the front end to make good decisions, and the kind of support they need once they have that health insurance card, right? Because it's great to have that health insurance card. It's supposed to give you that financial protection that we heard discussed earlier, hoping you'll stay out of bankruptcy. But it also is supposed to give you access to medical care, right? That's the whole purpose of health coverage. So we focused so much on IT that there just wasn't enough energy left, air in the room to focus on everything else. So we learned that. And the good news is that in learning from some of your research, which I so appreciate, and learning from our assisters and navigators and other folks on the ground, what works, what doesn't, we have been able to implement some critical decision support tools. In fact, we are one of the states, and DC is a state if you live here. We just need the right to vote. We added consumer textbooks plan match tool at the front end to help our customers make better decisions. This year we offer 26 different health insurance products on the individual side, 136 different products on the small group side. I don't think there's a single person in this room who has the time to look at all the products. So the consumer checkbook tool that we've been using for our customers that know about it and use it, it's 5 stars. We also have an all-plan doctor directory that also makes it easier for our customers at the front end. What we haven't done well, and that's why I'm so excited that I got to spend the whole day here taking a lot of notes on each panel, is what happens afterwards. What do we need to do now? So as a follow-up to this, I would love the opportunity for you to provide me with more information about your research and how I can implement it in DC to help my customers make better decisions and to understand how to use their health coverage. And the second big lesson is we would not be successful, and I'll say that again in case you were asleep or zoned out or checking your mobile device. We would not be successful if it was not for our navigators and our in-person assisters and our certified application counselors. They are the ones, they are the army on the ground. One of the things we've learned is technology is great if you use it, if you like it, right? It's worthless, really, for people who don't use it. For people in all ages, we have 20-some-year-olds aging off their parents' policy who are savvy technology users in every aspect of their life, they are afraid to make a decision such as which health insurance policy is best for them without talking to someone in person for that advice. And that in-person person they need to talk to is a trusted voice who they can relate to, a peer who they can trust to base their decision on. So without the in-person help, every year we would not be successful. And so for future opportunities to even expand the role of in-person help and assistance, I really encourage all of you in your individual capacities to figure out ways that we can provide additional funding for the groups on the ground who are really doing this where the rubber hits the road work. We cannot exist without that.
Yes,
So waiting to see if anybody else said, I think two quick things. One, picking up on a comment that Winston made about, the young and invincible and the old and decrepit. One of the lessons in the opportunity.
The old vincibles.
Old vincibles.
OVs, yeah.
Yes.
Well, dignified a little.
Okay. Well, I just repeating what he
Come on.
said. I like the over 35. But I think, one of the lessons and the opportunities there is that, particularly when putting the coverage to care hat on, the lessons of health literacy, it doesn't matter if you have pediatric Medicaid, it doesn't matter if you are in that Young Invincibles, it doesn't matter if you have employer coverage or if you're aging into Medicare, because one of the things when we started this, there were 500,000 people who were 64 and uninsured who were aging into Medicare. And so for them, the lessons of understanding your coverage, knowing what a deductible is, how to find a provider, getting preventive services and the importance of that, those are new for them as well to some extent. And we have actually found that the SHIP counselors who are working with the Medicare beneficiaries have been some of the biggest users of the resources because there are many people, it doesn't matter what age, who don't understand their coverage and how to get what they need. And then the other piece, kind of looking at kind of where we go and sort of those opportunities and still building on that, I think the point that was made also in terms of where people sit really kind of has a view of whether or not it's intuitive. And I think for us, when we look at who's left and still uninsured, part of it is reaching them. Part of it is making sure that they know what's available. But I think part of it is also something that builds a little on what Mira was just saying of like making the value proposition of why within your budget constraints of what you have, you should purchase health insurance coverage. And I think for the population that's left, that's going to be critically important or we're not going to get to them because they're, for some people, coverage is more affordable, but still not affordable.
I think, you're reminding me too, Cara, and I think it's important to realize the individual mandate is the new part of the law. However, having people who are eligible for coverage who didn't have it is a long-standing issue. It's heightened now, and it's really become part of the law that you must have it. But the numbers of people that were eligible for Medicare, Medicaid that did not have it is a long-standing, sort of embarrassing statistic, and one that health literacy even underscored 10, 15 years ago. What are the issues that are a part, that could be a part, that maybe we could deconstruct and begin to address? I think right now there's heightened attention to it because of the law, but the issue itself is pretty long-standing, so yeah.
So I'd like to share very preliminary survey data. We like to ask our enrollees about them, how they use coverage, what they know. We also like to ask people who never completed their enrollment why. And at least the folks who ended up enrolling, and the folks responded to our survey indicated that more than 50% of them have higher than a college degree, and another 30 have a college degree. So it's a pretty well-educated respondent population, all individual, privately insured through DC HealthLink. And about 5-6% of those folks said They didn't know that there is an individual requirement to be insured. And and even a slightly higher percentage indicated that they didn't know there was a tax fine, tax penalty associated with it. So to me, it tells me that we should still be educating at the front end, even though the care piece, the coverage to care piece is so critical, because that medical card is worthless unless people use it effectively. It just another lesson, we're not done educating people.
So before we move on to the next question, Kim, you used the word partnership. And yeah, partnership, that always sounds great. You know, yeah, a lot of people need to come to the table. Who needs to come to the table on this? Who are the partners that we need? And if we're really going to move this, you know, what in some ways can feel like a Sisyphean ball. I heard some great emotional responses to some of the presentations around me. I heard a couple sighs. I heard somebody say they were in catatonic, you know, a state of depression at one point. So, I mean, I heard some fairly emotional things. So let's say, you know, you happen to have, you know, some people who do want to be a part of it. Who are these critical partners?
So I would say that the critical partners are everyone that within the system. So for this to be a seamless experience for the consumer, for them to be able to understand what they need in terms of selecting their insurance coverage, and then how it is that they can use it and use those benefits, then you need everyone involved at the table, right?
So let's just name
payers, you need pharma, you need health systems, you need all of those that are making the policies and the rules, right? So state DOIs, you've got. So I think that there is no one that you can leave out. Everyone in the system must come together to partner.
And so where might we have opportunities in that? I mean, do we have everybody? Are they all there?
The list may be easier to name where we don't have the opportunities, right? Right. So,
and I'm just curious, you know, as we think about moving forward and where we are, and we heard a lot about, you know, like here are the elements of strategies, here are potential tools, here's where we are with them, here's what we need. You know, sort of key partners and key opportunities for moving forward. That's kind of what I was thinking about, given where we are now.
Right, and I would say that the most essential person or people in that partnership are the consumers themselves. So just the examples that we heard from Mad Powell, you know, user-centered design, human-centered design, having consumers be a part of designing these solutions are essential for us to have something that's going to work for them.
Other thought?
Yeah, I just, I mean, in just speaking about Connecticut, because that's what I know.
Yeah.
You know, we do have a great partnership and a lot of stakeholders that do come together. We have various advocate organizations. We have our Department of Social Services, which oversees our Medicaid program. We have other state agencies that provide clinical services, so it's important for them to be part of this collaboration. For us, I think there's a little disconnect with the providers. Mm-hmm. We need to do a better job of getting them in as in our collaborating with us and educating them as well. But I think you had it right too. The consumers, they really need to be a part of this. We have to get to them in a way that they understand, and everybody, depending on age and race and ethnicity, different cultural things, they learn in different ways, and I think we really need to break that down.
And I would say, I mean, that's one of the things where I think we have done well, in that when you look at, we had Champions for Coverage is one of the things where we signed faith-based organizations, social services, you had, I mean, just you name it. Mm-hmm. And those are all important. We had, you know, the providers, the payers. The providers are challenged because they are struggling with all of the other delivery system reform changes that are happening. And so having the time and attention to focus on helping consumers in front of them understand their coverage or learn about it, we got real pushback on that because they're drowning. And so I think being mindful of that, but where we are more successful is the social workers, the patient navigators within their practice who have a little bit more time, who do that patient education. So I think that's also more of an opportunity where we can engage. I think we also look at, sort of who's touching consumers where. So one of the things that I think is still an opportunity we've done really well, but thinking about like hospitals. And so the ERs where individuals are coming who may have coverage and are still using it because that's what they know. They may not have coverage. People who are getting admitted and then being discharged with instructions to follow up with your primary care provider in the next 30 days without the question of, do you have one? And sort of how do we bridge that gap? And there are a couple of people who are doing that. I think where we still have opportunity is a lot of these conversations, and I don't know if you said it as we were talking about this, a lot of these conversations happen in one-offs. Yeah. And so how do we share and bridge and connect a lot of those dots and the lessons that are learned across the states, across even just within the federal government, how do we do that better so that that information is being shared and used?
Yeah, Mila.
So I would argue that state-based marketplaces are inherently in a great position to bring together diverse stakeholders to the table. I can tell you in DC, in our first year, we had a gazillion working groups. Now we have fewer of them, but we still have standing advisory boards, various committees, and all of them have representatives with different voices: consumer and patient advocates, brokers, health plans, business owners. We have doctors. In some of our groups, we have hospitals represented as well. And what we do is we challenge them with a problem to give us a solution, a consensus-based solution. And we find that usually when people start out, in many cases, very different opinions, when you put them all in the room together and say, if you give me a consensus-based solution, the chances are my board adopts it, and we're quasi-government and have a private executive board, so we have that luxury. And so when we get consensus-based policy decisions from our working groups, we adopt all of them. And so states are in a really, state-based marketplaces are in a really strong position to convene, to bring together diverse voices to come up with particular solutions. The other point I wanted to share with you is, so many of our customers do use our website, they rely on it, and they actually don't like to talk to people if they can help it. And so to serve that segment, all ages, not just the 20-some-year-olds, but we see that at all ages. What we've been doing is trying to simplify the website. Someone earlier said people expect a commercial Amazon-style experience. It's true, they do. If it takes too long, if there are too many screens, people just stop. And we know that because we can see where people stop in the process. So we've done a lot over the last couple of years to simplify. We started with like 26, I think, screens. We took that down to 11 for full pay people. For employees, 20-some screens to 6 screens. So we've really simplified. And to help us with that, we really paid attention to customer feedback. Even the screaming customers, it mattered. What we're doing now is I have a person whose job it is to meet one-on-one with our customers who use our website and observe how they use it and take notes and note where they pause and then ask questions. Was this confusing? Did you understand this? And get feedback. And the luxury that I have that some may not is and this is probably I'm gonna lose you by saying this, it's IT talk, but we moved from a very hard-coded, hard-to-change IT system to agile, open-source software. So I can actually, one person in the room gets it, thank you. And so I can actually make changes every day to my system. So the feedback that I'm getting from my users matters. And that's why I started my comment to you by saying, please give me your advice. What can I do better? Because I can actually implement it pretty quickly. And so That kind of one-on-one observation of what my customers experience informs what I can do better to simplify. We've also added standardized plans. Karen Pollitt's talked about the complexity of products, and we all know it's true. And the standardized plan, we also offer non-standardized plans. This is the first year we have standardized plans, which is standard benefits and standard co-pays, co-insurance deductibles, so consumers can compare apples to apples. The standardized products are the hottest selling products this year for me. More than 40% of my customers choose a standardized product. It's remarkable.
Can you just describe what that means a little bit more so we're all on the same page about what exactly is a standardized product? How would I know when I see it?
So on our website, we have nudges. Someone else talked about nudging people. So essentially, a standardized product has all the benefits are the same, so no matter who sells it, whether it's the Blues Plan or Kaiser, no matter who's offering it at that level, if it's an HMO or a point of service or a PPO, all the benefits are the same, no difference in benefits, and all the deductibles, the co-insurance, the co-pays work the same way. So there are no differences. So if there's, I'm going to make this up, if there's a $500 deductible for prescription drugs, that is the deductible in all of the standardized products in a metal level. So it's very much apples to apples. So consumers essentially shop based on the premium for that as well as the network. And we're hoping eventually they'll also consider quality. But it's an easier way to make decisions. And by the way, we also have other nudges which work really well for us. We were finding that people who were eligible for cost reductions, cost sharing reductions, were not enrolling in silver plans and therefore losing that. And so now we have nudges, which if a customer is choosing, a gold plan instead of silver, there's a pop-up window that says you will not receive your cost sharing reduction if you choose this plan. And it's worked really well. Most of our customers who qualify for cost sharing reductions, in fact, now choose silver plans. And the other nudge we have on that is when customers search and they qualify for cost sharing reductions, they see the silver plans first. So I just want to comment on the earlier speaker who talked about how nudges could help people make more informed decisions. We're seeing firsthand that it's working. The nudges work.
So let me push us to see. We heard repeatedly that health insurance is complex, it's complicated. Can you think of specific things going forward that could make it more understandable, more usable, more navigable, that should be a part of, they're on the list. They're part of what we all need to really put at the top of our thinking when we think about health insurance literacy? What should we really be highlighting there? I mean, I think one thing you've just spoken to very clearly, and that is some sort of standardization of content that makes the content more navigable. That's an example, and I think it transitions very well into this. Can you think of other approaches to actually making health insurance itself?
So, health insurance, yeah.
Take a deep breath.
Right.
Drink that virtual beer. Here we go.
Take my hat off of where I'm sitting and talk as a private citizen. No.
Okay, you can be that too.
No.
She can't. She tried.
No, I was going to say, because the standardization is definitely important. I think one of the other things, and I think we were hoping somebody was going to talk about it, but there's that sort of just-in-time information. So trying to think about what is it that consumers need at a particular point in time. Because having gone through the process, we've gotten the screen numbers down across the board of how many screens it takes for someone to complete coverage, but it's still a big hurdle. Mm-hmm. And so the variation of who's ready for information at that point in time is huge. And what do you give them at that point in time? So There's some efforts that are underway to look at what is it consumers need as they're journeying on that path from coverage to care as they start to go in, or they're getting ready to think about finding a provider. What information can you nudge them with, give them at that point in time? I think we continue to do the Chase campaigns, so reminding people about coming back and if you've had a change in circumstance, because we don't want people to lose coverage as well. And so maintaining the continuity of coverage. What is it that we can do? Taxes, the back to school. How do we continue to prompt people to think about this year round is one of the other efforts. But I think that the next big area is really that just in time, so you can give people the bite-sized information that they need without overwhelming them.
Other thoughts?
I think we could really do a better job at explaining in a simplified way all of those preventative services that are free. A simple word is they are free. It makes all the difference in them utilizing it. We do see this a lot. I mean, there are people who've never had insurance before. They don't know how to use it. Now they get it. They don't use it because they're afraid it's going to cost too much. And when you really sit down with them and simplify, well, did you know that this, and preventative is a foreign word to them too. These services are free to you, very simple. They sort of get it that way. So I think it's really just really breaking it down that way to get them to utilize it. Again, as I say, utilize it to their benefit.
Yeah, I would agree. I think language is very important, and I think that something that we've seen is that the word preventative is not an easy one, but also free is not, because everyone's mother taught them that there is no free lunch, and and really when you talk about preventive services, they're not free. If someone comes to you, Ruth, for a wellness exam, you don't give that to them free, right? It's just part of the coverage that is part of their premium, right? It's part of what is a benefit to them that is rolled into their premium. And so I think language is very important, because what we see then, and I can tell you I have coworkers who tell me that, I don't believe that. I don't believe that my preventive care is free. And they will wait until they meet their deductible before they go have their breast cancer screening, before they go to their wellness exam, because they have been surprised before, after they went to the physician's office, with a bill.
Oh, it happens a lot.
Yeah.
So that might be a problem.
It's also not free.
Exactly.
It's not free because it's an opportunity cost for the patients. In England, you're reimbursed for your travel for your breast cancer screening. There's an opportunity cost for you.
Exactly.
You miss a day at work.
There's,
This is not
exactly. Yes.
Yeah, so.
Yeah.
So I agree with everything that's been said. I would add that it's really important to recognize the diverse populations that are covered. And one of the lessons we learned on the enrollment side of it is that it's a trusted messenger that matters. It's not me telling someone, oh, you should sign up. If you go skiing and have an accident, you'll have coverage. It's not me doing that. It's peer-to-peer. And I think we're starting to see some of those same lessons play out in how you use your coverage. Who will your coworker trust that gives the message, no, you don't have to pay for the mammography screening. You don't get a bill, and if you do, it's a mistake. So I think it's really important. In DC, we have a high immigrant population. It's a very diverse community that we cover. And we've learned that it's how you say it, it's when to say it, it's really who says it to you and how often it's said.
Let's go on to the next question here. Someone, if it's not, there we go. So what about networking of best practices? You've mentioned some of the practices that work well. Where are we with the networking? How do we advance that? How do we get what's good shared and advanced by others? what are our biggest successes there, and where are there opportunities?
Well, I'm sorry. So in Connecticut, when we're talking about the in-person assisters, which the first year we got funding for, and it worked out wonderful. We unfortunately do not have any more funding, but those organizations are committed to the communities that they work in, and they will do everything up to the point of actually enrollment because they can't. And then they send them to a certified application counselor or a broker. And I think we lose some people enrolling because they don't trust that now. So that, I think that's been a great practice in Connecticut. I think sharing across the states is really important. I don't feel that we do that enough. There was a lot I learned today that I didn't know that was going on that I'm really excited about. So I think, you know, if we could somehow have some sort of collaborative effort and discussion on what works across the states, that would be really helpful.
Yeah, and I would add, I think one of the things that we have built on and done better is with our, and I'll talk about the assisters and sort of the navigators. So there's a regular Friday call that's pretty much open to anybody, and we've gotten better at honing in the types of information that our assisters need and how we share that and passing that along. I think, you know, one of the things I was thinking about within our agency and within CMMI, we do, Center for Medicare and Medicaid Innovation, we have learning collaboratives. And so providing a little bit more of that space for the lessons to be shared across and how do we bridge that. And so thinking about how do we foster some of these learning collaboratives so that it's a little less didactic of here's, you know, some of the information and, you know, maybe get a question, but really giving some of that space to be a little bit more creative would be another way I think that we could really help in sharing some of those best practices. And then I think, you know, it's also sort of where do you go to get the information? Yeah. And so they're, you know, we heard about the Library of Medicine and the collaboratives that they have and the work that they have, but thinking about where is it people want to go for that information and how do we put that information in a place that is a little bit easier for people to access.
So, yeah, Mila, I'm very curious your experience.
So I'll start by saying we've always had a very limited budget for outreach and marketing, and DC is a very expensive media market, and it gets more expensive during elections. So we learned that lesson early on in 2013. We had a governor's election in the neighboring state, and so we had to do things, you know, pennies on the dollar. And I have one of the most creative marketing outreach directors probably in the US. She actually wrote a college textbook chapter in a college book on how to do things on a small budget. And so first year we did things like we partnered with the faith-based community, and we saw that every time, you know, on Sunday you heard about Obamacare being the Jesus Health Plan, the next day we had a spike in our enrollments. You know, every time we went, like this past year, we went to Star Wars and Hunger Games at the movie theaters. We actually did small ads, but there were long lines of people, and so we had an opportunity to give out literature. We did that. We did things like, well, not me, our navigators and assisters went to bars and nightclubs, and then they went to diners in the middle of the night. That's where people go after they're done at the nightclubs. So we did those kinds of things. And I could go on and on.
The old Vincibles.
The young and the more mature.
Yep.
All benefited, you know, Pizza Bowl or Super Bowl Sunday. When you ordered your pizza, you got a little brochure. Don't forget deadline is coming up. Sweet 16, we were at the sports clubs, not me again. And all of those things are relatively inexpensive, and they work well. And when we shared that information with our sister states and with the Obama administration, I have to really give a huge round of applause to the administration. The folks we work with do a great job organizing calls for the states as well as with other stakeholders. And we've been on calls with the Sisters and Navigators, and I've sent my director of outreach to talk to panels in rural America every year about what we do. And so we are, and sometimes it's at an expense to me out of my budget. But I feel it is so important to invest in that sharing so others could benefit from what's worked well for us. It's paying lots of dividends. So that's some of the ways that we've been sharing some of our successes.
And I think it's also, not to over-label, but we've heard it repeatedly today that the 30 million now that remain without health insurance and continue to need it are even harder to reach and enroll. And I often put a face on that because I think of the patients that I see who are among those 30 million and who they are. And I think it's also, we talked about the importance of in-person assistance. There's no way somebody could get one of these patients enrolled in 90 minutes. If they can, they need to be hired tomorrow. The levels of the onion that have to be peeled to get back underneath all the complexity of the life and the context and the meanings that are underneath, the faces that I see when I think of the 30 million that are still there. So that kind of, it leads us into the next question, which really is about the level of, next question, thank you. But it has to do with this thing about the allocation of resources and this true one-on-one. There's a piece of me that thinks, yeah, I think most people would like that. Now, I know there's some who wouldn't, and that's great. But you could get a little sticky here because if you had the resources for everybody that needs them, you're going to have a lot of people that would like to use that. But they need to go online and just deal with it and take care of it because, what it would take to have one-on-one resource counseling for every single person, to have every question, that's a lot. And all of that translates into cost and everything else. So you clearly want to have efficiency as much as possible. But there is absolutely a population that are real and in need that will not and cannot make the enrollment without an intensive one-on-one engagement. What are we going to do? How are we going to get there? Tell me if I'm wrong, but that's certainly how I see it.
I don't think you're wrong. I think that...
And 30 million, that may be conservative.
I think so. When you break down kind of who that crowd is, there's still some people who are unfortunately in states that haven't expanded Medicaid. So that's going to be a challenge in terms of the reaching of them and the affordability of it. I think there's some things that there's an organization that's done, I thought, what was a really interesting model. And it's the Maricopa Integrated Health System, where they have cultural health navigators. And these are individuals who are working with consumers, actually training these individuals. They eventually get hired into their system, but they're not just there to shepherd them through the health system. They're also going to their home and doing home visits. They're also
more than 90 minutes.
More than 90 minutes. They're, utilizing them, helping them connect to utilities. So we heard about, some people who don't know how to use a mouse. Their population is a large refugee population that they're working with. So an elevator is something that can be new for some of their consumers. So thinking about how we make the business proposition for some of the larger organizations to take some of this on a little bit more, I think is one that we should really kind of think through, because the budgets being what they are, they're not likely to grow significantly. So I think, how do we get creative about connecting people up and making that case?
Are you doing anything in Connecticut on this, Laura?
When we had our Navigator in-person assister program, part of it was federally funded, and then the other half of it was funded by some advocate organizations, which we do periodically go back to, and they've been wonderful in providing funding for that. And unfortunately, we didn't get continued funding, and it's really been very difficult for us. Right now, Connecticut is faced with adults and caregivers of children who are on Medicaid losing their Medicaid, having to go into one of the qualified health plans. And that's about 20,000 people, and those are the most difficult to reach. And we don't have the assisters now on the ground to reach them. They have until the end of the month to do that, to make that transition. And I think the last figure I heard was that only 26% of those 18,000 or 20,000 have enrolled. So, you know, I don't know what the answer is for how do we, you know, fund something like this. How do we, you know, I think we need to get really creative in how to do that. You know, I'm sure as every state, as is Connecticut, is in a budget crisis. So, you know, I doubt that that's going to come from the state side. I'm going to throw this out there, and probably all the people here who are from the carriers are going to hate me, but our agency is funded through our insurance fund, which is assessments placed on the carriers. And I know that may be one avenue to look at, but we can't always go to the carriers to, you know, be able to fund these projects and programs. So I think, I mean, I don't have an answer. We need to be really creative in that.
Yeah, Mila.
I have the answer, but it takes
go,
the will.
just like that.
It takes the will. So, you know, when you get sick, it's not a, you know, no one asks you, did you vote for a Republican or a Democrat, right? It's not a political thing. Using your health insurance, getting access to care, it's really not a political thing. And so I think our elected officials in Congress should be asked for a commitment to fund Navigators and consumer assistance programs and in-person assisters. It's critical to get people coverage, and it's critical to help people use their coverage. So if there's a will to do that, then we have a way. The other point I'd make is I had about $800,000 in federal grants that I essentially provided to in-person assisters, then another 150 out of my budget. So all of that is going away. I built into my own budget $500,000 so I can continue providing the financial help that groups need in order to help me and in order to help the population I serve. So it is really important, and I know that all state-based marketplaces have built into our budgets that ongoing funding. It's not at the same level as we had when we had federal grants, and that's why additional federal grants could be so significant. Plus, I'll just say this, if you want risk pools to be stable, you absolutely have to get new enrollees in, because as if no one new is coming in, your pool ages, you have more claims, and your premiums get more expensive. So it's really, enrollment efforts are important for at least two reasons. One is we want to get to the remaining uninsured, and it's important to keep the risk pool stable. I'll also add, in DC, we have very low uninsured. In fact, the Affordable Care Act helped us reduce the uninsured by 20%, according to the latest census. But we're not at 100% yet, and we're trying to get there. The 3% of our population without coverage, the main reason for that is affordability. And APTC, the premium reductions, are not sufficient to make it more affordable. So as we think about the next generation of enhancements to the Affordable Care Act, when the opportunity comes up, we really need to also be looking at the front-end affordability the premiums as well as the deductibles and the other out-of-pocket expenses that continue to keep some people uninsured.
That's great. So I think the clarity on what the issues are and being able to articulate them, being an advocate for what we know would work and what is needed and being clear on it. I think when it's muddled and you can't, we're not able to articulate what's needed and what we know works, we're certainly not closer there. So I appreciate, underscoring the clarity there is about that, because I think it's really important for everybody I think we got it. I think we've heard it repeatedly, but I think it's absolutely worth underscoring because I think it's come up on every single panel that we've had. I've heard it.
One other idea, and I don't know how we had some initial conversations way back when. The schools of public health.
Yeah.
I mean, this is part of when you look at what a public health individual is supposed to do, education is part of this. And so how can we, and had some initial conversations, but I think that's an untapped pool to some extent, or a slightly tapped pool that could be much heavier leveraged and resourced to engage with the community, to help them to understand and to make it part of their curriculum.
And it could be a competency for having
It is
an
a
MPH,
competency, yeah.
like a stated competency. We are going